so you're talking to nobody. Just pretend like you're...
To help the speaker relax.
All right. Looks like most people are getting settled, so I think we're going to try to start a little bit early and hopefully end a little early and get everybody back upstairs for the next session. So welcome, everybody, and thank you for attending the Future of AI in Pathology and Laboratory Medicine Discovery Cafe session. We're pleased, as Chris mentioned upstairs, to have a record turnout at the forum today, so thank you all for attending. We have an hour and 15 minutes for our session today, maybe a couple more minutes since we're getting started early. We'll go until a little bit before 1 p.m., and I'll help us stay on time. We'll include a question and answer session at the end, and there's a microphone in the middle for your questions. And it's now my pleasure to introduce your moderators. The first moderator is Dr. Jeffrey Golden. He's the on the far, my right, your left. He's the chair of the Department of Pathology at Brigham and Women's Hospital. He's also the Ramzi S. Cotran Professor of Pathology at Harvard Medical School. The other moderator today is right here, Dr. David Lewis. Dr. Lewis is the Pathologist-in-Chief at Mass General Hospital, and he's the Benjamin Castleman Professor of Pathology at Harvard Medical School. So they'll introduce our panelists, and enjoy, please.
So thank you very much. And I also want to extend a welcome to everybody. I think this is going to be a really exciting session. I'm just going to give you a couple of formalities of what we're going to try and do here today. First, we're going to give our experts, which are really sitting between David and I, we're going to give each of them a few minutes to speak on their particular topic. And we've chosen specifically a variety of topics that cover the scope of what happens in pathology. And that'll be after David and I give a little bit of an introduction. We're going to probably ask them a couple questions, but really the focus of what we want this to be is getting your questions and having an opportunity to ask your questions. And I'm going to make a plea right now. The lights here are really bright on all of us, and it's hard for us to see anybody who's out there. So if anybody has a question, please go up and use the microphone. It's hard for us to hear it if we don't, and we may not see you if you just raise your hand. So to begin with some just introductions, to my left is Kun-Hsing. Kun-Hsing is a postdoctoral fellow in the Department of Biomedical Informatics at Harvard Medical School and also has a position within the Department of Pathology at the Brigham and Women's Hospital. He's done some really excellent work in using AI for image analysis, and that's what he'll be telling you a little bit about. Next to Kun is Reiko Nishihara. Reiko works in the basically the interface of epidemiology, pathology data, and clinical data. And she's going to be talking to you a lot about how you integrate multiple types of data and use different types of modeling to understand that. So for other introductions, I will introduce David Lewis at the other end, who you've heard from or heard about. David?
So thanks, Jeff. I'm going to introduce the two folks to my right. Immediately next to me is John Higgins. John is an expert in hematology and immunology laboratory testing and is a member of our pathology department at Mass General. He's also an associate professor of systems biology at Harvard Medical School and has an interest in blood cells and how to measure them and use their measurements to evaluate human disease. And immediately next to John is Dr. Joe Lennerz. Joe is also from the Department of Pathology at Mass General, and his expertise is in molecular diagnostics, using gene analysis to help manage patients. And Joe is an assistant professor of pathology at Harvard Medical School. So to set the stage for what we're going to be talking about today, I'm going to tell two stories. And it's because many of you in the audience probably don't think about pathology and laboratory medicine every day of your lives. You're not lucky enough to be like us to think about pathology and laboratory medicine every day of your lives. So the first story I like to tell when explaining what we do is to relate that scene from The Wizard of Oz. So when Dorothy and her fellow travelers finally come in to meet the great Oz, they see this huge holographic projection on the screen. It's a very, very impressive image, and it's finally the great Oz. Now, that's sort of what happens when a patient comes and meets their great doctor. The surgeon comes in with a white coat, their very impressive figure, and is going to give you an answer. But remember what happens in the scene from The Wizard of Oz is that Toto, the little dog, runs over and pulls the curtain away, and everybody starts staring at the man behind the curtain moving the knobs, and the great Oz on the screen says, "Pay no attention to the man behind the curtain." So the men and the women behind the curtain in the healthcare scenario are the pathologists. We're the folks that are giving information so that when the great surgeon comes in to meet a patient, he or she has an answer for that patient. And it's estimated that about 70% of medical decisions, 70%, both in the inpatient and the outpatient setting, are based on the laboratory results coming from behind the curtain. So that's the first image I'll leave with you, is the folks operating behind the curtain to give answers so that the great Oz can appear in front of you as a patient and give an answer. The second story I'll tell to paint a picture of what's going on and where we see the field of pathology going is one that's told by a guy named John Gilbertson that all of us have worked with. And John had an observation because he has a family farm up in New Hampshire. And what he noticed on the family farm was that he found all sorts of instruments there, a barometer, a thermometer, all sorts of things that the farmer bought about 100 or 150 years ago to try to learn how to predict the weather over the next few days at his farm. If he could predict the weather, he might do a better job managing his crops or his cows or whatever he was doing on the farm. If you think about it, each one of those pieces of equipment, the barometer, the thermometer, the weather vane, took money to buy. He had to learn how to use each one of those pieces of equipment. It took time. Then he had to learn how to integrate the data from those different pieces of equipment. And at the end of it all, after all that time and money, he did a pretty poor job of predicting the weather over the next 3 days at his farm. Today, that same farmer flips on the TV for free and instantaneously, or pulls out his or her smartphone, and again, free and instantaneously, gets an extraordinarily accurate forecast of what's happening in the next 3 days. The deceptive part is what's going on behind the man in the funny tie on the TV giving you your weather report. And that is massive amounts of data. Right? There's data coming from 100 years of weather data, weather reports. There's data coming from weather balloons up in the air, weather stations on the ground. Those are all being fed into complex fluid dynamic models, all to yield a prediction that for the end user is quick, accurate. And that's where we see laboratory data going, laboratory diagnosis going. We want to be able to be the folks who are taking large quantities of data, and Jeff's going to tell you about that data in a minute, but large quantities of data and doing something intelligent with that data so that when the great Oz comes to meet the patient, he or she will have great information, predictive information to share with that patient. So I'll leave you with those two stories and turn it over to Jeff now to talk about the types of data that we use in pathology.
Data is exactly why pathology is so well positioned for the use and the implementation of various forms of artificial intelligence. If you just look at on a pure volume level, pathology is where roughly 70% of the data in the electronic medical record resides or comes from. Partners Healthcare, about 4 to 5 years ago, had to convert all of its data for clinical use to a new electronic medical record, and that new record was Epic. And when we did that, we decided to convert in real time 5 years worth of our patient data. That's for 5 hospitals, 2 academic medical centers. And all the data before that is retrievable, but it was archived. For that 5 years, we looked at that, and the second most common report was a radiology report. And over those 5 years, there were 14 million radiology reports. A lot of data to be able to use. For pathology, that same period of time, 500 million reports. And one report could be an entire genome, 3 billion base pairs. So it is deep data, and there's a lot of it. What is that data? Well, it includes chemistry data. So every time a sodium was collected on a patient, a chloride. It includes hematology data, a white blood cell count, a red blood cell count. It includes microbiology data, all the different types of organisms that were grown, tested for, and identified. It includes molecular data, testing on germline mutations as well as somatic, cancer mutations and other somatic disorders. It includes all of the histopathology data, a report of an image, and we'll talk about the amount of data that's required in each of those images. Sometimes a single glass slide being more than an entire MRI of a brain. All of this data is being generated in the pathology laboratories and being put into the electronic medical record for that physician that David was just talking about to be able to use for helping patients with whatever they come in to see their physician for. Now, one of the problems with this, and a very nice study that was done by ARUP, National Reference Lab, is that a clinician can use about 5 pieces of data at one time. So if you go in for your annual physical exam and they do what's called a CBC, a complete blood count, they do a simple metabolic panel with sodiums and potassiums and chlorides, they maybe do a lipid panel, a clinician's going to get somewhere around 20 to 30 different data points, and they'll be able to use, at the most, 5. But all the rest of that data has value. And that's what we're going to be talking about today, is how do we take that data and enhance the value to improve care? So with that, we're now going to hear from each of our panel of experts. We're going to give them each just a few minutes to describe what they do. Like I said, we might ask them a couple questions, and then we're going to turn it over to all of you to answer the questions you might have around pathology. So with that, I'm going to ask Kun-Hsing to tell us a little bit about anatomic pathology and image data.
Sure. Thanks, Jeff, for the introduction. So in our lab, we are working on an artificial intelligence system to analyze the whole slide pathology scan. As we all know that pathology evaluation is the gold standard of diagnosing many types of complex diseases, especially different types of tumor. And in our lab, we are trying to augment and enhance this pathological evaluation process. So we first acquired the whole slide scan samples in the digital form and built machine learning and deep learning methods to correlate these image findings with our outcomes of interest. We are currently focusing on 3 different outcomes: patient diagnosis, survival prediction, and the association between genomics and histopathology. So as an illustration, for our first use case, the diagnosis of diseases, in our previous published paper, we acquired more than 1,000 cases, all with non-small cell lung cancer. And we developed a machine learning system to quantitatively analyze the slide, bypassing any human intervention. So first of all, we developed a method to extract more than 9,000 features directly from the slide. And those 9,000 features are the visual summaries of the tumor cell, the tumor nucleus, and the tumor stromal regions. And we are able to identify those image features as a summary and correlate them with patient diagnosis. So for the diagnosis of the lung cancer task, we've achieved more than 95 to 99% accuracy, which is pretty much on par of many of the general pathology practice. And we also look one step further to see if we can also see something that human eyes cannot see. And one of such things is about patient survival prediction. Currently, patient survival is a pretty daunting task because it relies on a lot of different factors, some clinical factors, and some factors about the basic pathology findings. And in our lab, we basically use the AI system to try to find this correlation between histopathology morphology and patient survival. So going back to the lung cancer use case, we also acquired the overall survival data by mining the electronic medical records. And we are able to correlate a subset of these 9,000 features that are informative of patients' overall survival. And we are able to build a machine learning model that differentiates the longer-term survivors from the shorter-term survivors in the stage 1 lung cancer cases. And this is particularly useful because currently we all know that for the stage 1 non-small cell lung cancer patients, they suffer from a wide variety of survival outcomes. The median survival is around 5 years, but there's around 10% of the patients who wouldn't survive past the first year, whereas there's still 10 to 15% of patients who could survive for more than 10 years. By better informing the patient prognosis, we can inform the doctors and the patient on choosing the optimal treatment to the patient to ensure individualized and personalized medicine. And in the third use case, we correlate the genomic patterns with histopathology findings. And one of such use cases is to predict the clinically important and actionable mutations, such as EGFR mutation in the lung. Because for EGFR mutation patients, there are a couple of FDA-approved drugs that can benefit this patient by elongating their survival or even eradicate their tumor with this type of mutations. But the association between the image findings and EGFR mutation is not previously known. So by this systematic analysis, we are able to look into the pathology slide, identify what is hidden inside of this slide, and discover those novel image patterns associated with any outcomes of interest. And we are currently extending this pipeline to multiple tumor types beyond lung cancer. We have successful prototypes working on brain cancer, breast cancer, ovarian cancer, among others, all with pretty significant results. And we have filed a patent on this process of acquiring the tumor slide, making it into digital form, and selecting the regions of interest so that we can develop AI system out of it. So the overall goal of my analysis is to enhance the current pathology practice by identifying the novel patterns hidden inside of the pathology slide and use AI system to correlate them with important clinical findings. Thank you.
Thank you, Kun. Maybe you could just expand a little bit on what you view as the challenges to implementing a system like this in a more routine clinical care.
Sure. That's a very important point. So currently, all our analysis is done in a research setting. That is, all the patients we collect the historical data from the medical records, and we build this system in our lab. So we can refine this system and make sure that they have adequate performance in this research setting. But in order to push this system into clinical practice, the first thing we need to do is to validate its actual clinical use. For example, we will need to set up some prognostic clinical trial to validate the prognosis of our system and maybe compete our system with expert pathologists head-to-head to see if there's any value that can be provided by our AI system. So that is one of the major challenges in pushing this forward into the clinical settings.
Great, thank you very much.
So thanks, Kun. He's just told you about a portion of pathology that relates to biopsies, tissue analysis. Another huge area in pathology is all of the blood work that we do, what we call clinical pathology or laboratory medicine. And so John Higgins is going to talk about some of the applications of technologies like AI in the area of clinical pathology laboratory medicine. John?
So I think one important advantage of the clinical pathology data is, as Jeff mentioned at the beginning, that the routine tests are ordered on most patients, and AI and machine learning methods are most powerful when the data that you get is highly accurate, but also when it's collected in an unbiased way. And as all of you probably know, when you have your annual physical, the doctor almost always orders a blood test, no matter what your past medical history or suspected future prognoses are. So those blood test measurements are not biased by the physician's expectation for what conditions may be present. So you end up with unbiased, very accurate measurements. And also, a little known fact is that a lot of the current clinical instruments in the clinical laboratory themselves are high resolution, high throughput, single cell measurement systems. So for instance, Jeff mentioned the blood count again, which currently most physicians will only use about 4 numbers from. But to provide those 4 numbers, most routine clinical hematology analyzers will actually make about 100,000 measurements, single cell measurements on each blood sample. So this data is a huge untapped resource, and the methods from artificial intelligence and machine learning can make use of that in ways that traditionally we haven't been able to.
Yeah, and I'll put an exclamation point on that. We talked about, and Jeff talked about, the amount of data that is sitting in the EHR already from pathology tests. But as John's telling you, there's a tremendous amount more data that is sitting in the machines that is waiting there for new approaches to look at and to hopefully derive diagnostic information from. So John, maybe just tell us a little about your own work analyzing blood cell values and how that can be used to predict disease.
Sure. So we've actually been working with this raw blood count data. And just to explain why 100,000 measurements are needed, the routine test will tell the physician what fraction of volume in the blood sample is occupied by cells. So when a test tube of blood that has about 5 milliliters of blood in it, when that's collected, we want to know what fraction of that 5 milliliters is occupied by cells. And in a healthy person, that's about 40%. But in order to make that measurement, back in the day, the tube would be spun down and someone would just hold it up to the light and make a guess as to the volume fraction. But nowadays, typical clinical lab instruments will actually extract all the cells from a known volume of blood and then measure the individual volume of about 50 or 60,000 cells, add up all those volumes, and then infer the fraction. So what my research laboratory has been trying to do is figure out what can we learn about the patient's physiology from that 50,000 point volume distribution. And one of the things that we have discovered is that in early stages of anemia, so when people's bone marrows, for instance, don't have enough iron in order to make as many new red blood cells as the patient needs, then the body apparently holds on to old blood cells, and that leads to a particular change in that volume distribution. And that change is actually a compensation for decreased production. So the blood count itself doesn't change. That fraction of volume that's occupied by cells is stable, but the volume distribution does. And we're able, in a number of cases, to predict an anemia a few months before it actually appears. And I also want to point out that the hematology analyzers are only one example of high throughput, high resolution data in the clinical laboratory. I think one particularly exciting technological development is that a lot of these really accurate measurements are making their way to point of care devices and even to consumer devices. For instance, continuous glucose monitors are now pretty routinely available for diabetic patients. And those allow patients to measure their blood glucose with high accuracy every 5 minutes, 24 hours a day. And that's another very rich set of data to study physiology.
Thanks, John. And again, just to emphasize, oftentimes when we think of new diagnostic tools, we think of having to generate them through big, expensive new machines. What John's talking about is taking existing data that's already there, free, and doing intelligent things with it to make new diagnostic approaches. So I'm going to turn now to Joe. As I said, Kun talked about biopsies, tissue diagnosis. John talked about blood-based diagnosis. And Joe is going to talk about DNA or nucleic acid-based diagnoses, molecular genetics, which is operative both in the tissue world as well as in the blood world, but raises new challenges for diagnostics. So Joe?
Thank you, David. Can I see a show of hands who has something to do with genomics? Just out of curiosity. Very interesting. I presume next time around there will be more. So I think the next frontier of molecular diagnostics is the interrogation of genomic sequence. These are millions of bases that are covered in parts about 300-fold. The first step is that all these data are absolutely not understandable to a human in its raw form. For example, they have to be mapped against the genome, which is, I mean, it would be theoretically possible for someone to screen all the millions of bases to find where one fragment of 100 bases just matches. But by default, we use bioinformatics tools to align against the reference genome. After these millions of bases have been aligned, there will be a variant file created that will list what is actually deviations or what deviations there are from the reference genome to actually make our calls. And just to illustrate to those in the room who have nothing to do with it, you can imagine, or if I draw a picture of a ginormous Excel spreadsheet where each row would be one variant, and there would be about 4,000 variants for a typical oncologic panel for one single patient, one single sample. So there's 4,000 rows of data, and if we talk about the columns, it would be initially just something like it's an A to a T change. That by itself is relatively meaningless because that could occur 1 out of 4 times over the genome. But what's attached are about 500 to 600 columns of so-called annotations or features. For example, what chromosome is this on? What is the position? What is the band on the chromosome? What is the gene affected? What's the exon? What is the predicted amino acid change? And some of those columns are so complex that people worked on a single number pretty much, for multiple years. For example, is this a site that's evolutionary conserved, or is this a kinase domain? And all these annotations for each single base change has to be digested by a human to say, do I want to call this, meaning do I want to put this in the report? Now this complexity clearly exceeds human capabilities. So one of the projects that we started about 2 years ago, and this is a completely clinical use case. So this is a CLIA approved lab where we want to report this for introduction into the medical record. So different validation standards apply. So what we try to build is something fairly simple, because if we break down our work, it actually means, do I want to put this in the report or do I not want to put this in the report? Classically in pathology, all the work that we do that will not go into a report is lost, meaning all the findings that we make and say, oh, this variant is interesting, but I do not want to put it in the report is value added, yet value lost, because it's not tracked in the electronic medical record, but we spend a lot of time doing quality assessments. So what we built is a classifier from a scale of 0, do not put in the report, to 1, put it in the report, basically like a percentage sliding scale. And we could set certain thresholds to say we want to put this in the report. So by taking into account all of the variants that we ever reviewed, and this is from a practice of about close to 100,000 variants, from about 10,000 patients that we actually called, and 6 different board-certified pathologists, we took this distilled out call practice and built an AI classifier to build this. And the percentage ultimately for precision and accuracy was way beyond 99.9%. So in essence, we applied this to, in a way, extend our abilities, but also to take into account all those columns that we cannot possibly process at any given time. So I think that's a use case. And I know that there's a lot of emotional connotations, but we applied it in a clinical setting. It makes our work much more effective, and it's clearly not an alien attack or something like that.
So it's a fascinating concept here because doctors often consult one another to get an opinion on a patient, and pathologists do it also, where you would ask someone for an opinion on an interpretation of a slide or a lab result. You have to find the person. Hopefully they're not on vacation. Hopefully they have time to help you. What Joe and his team have developed is essentially the virtual consult. So if he can't find his boss, John, he can ask virtual John for how virtual John would have made that call on a case. And we'll talk about it a little more later, but there may be other examples throughout medicine where virtual consultation has a pretty powerful impact.
Okay. What you've heard about is really a broad swath of what happens in pathology, from the anatomic, the tissue side of it, the blood, and all the data that's collected there, not only what's reported in the electronic medical record, but also what's in these instruments and all the data that exists, and molecular data. Ultimately, though, when we start thinking about caring for patients, these are not silos of data. They actually do interact. And so Reiko Nishihara and her colleagues have been very interested and have come up with some novel methods to actually bring that data together. And I'm going to let Reiko describe that.
Yes, thank you very much for your introduction. So my field of expertise is biostatistics and bioinformatics, and I design and analyze high-dimensional studies within large population-based cohorts, including the nurses' health study and health professional follow-up study, if some of them know. Some of you know. Those are Harvard cohorts, and originally those cohorts included almost 200,000 healthy participants. And currently focusing on colorectal cancer, I integrate lifestyle, diet, circulating blood markers, all of which are collected before they develop colorectal cancer. And once after some of them are diagnosed as cancer, we further collect clinical data, post-diagnostic lifestyle diet information, as well as tumor tissue from those patients for genomic sequencing, RNA sequencing, and protein expression analysis. So one of our studies, published studies, found that adiponectin level, which is a blood circulating biomarker and the indicators of obesity, could predict the occurrence of KRAS mutation in colorectal cancer. In another recent study from our research group found that the aspirin use after the diagnosis could prolong the patient's survival when those tumors, their tumors, didn't express PD-L1 immune checkpoint blockade, suggesting the possible combination immunotherapy of aspirin and PD-L1 inhibitor. So we are currently applying machine learning algorithms to our rich data set to better predict disease occurrence in healthy participants and predict also a patient prognosis once after they are diagnosed. So as a data scientist, I also currently studying the published machine learning studies. And I found that in addition to pathological, genomic, transcriptomic, or other omics data, clinical text data itself or lifestyle, environmental factors can be integrated to better predict disease behavior and better predict the tumor subtype or disease subtype, severity of the disease. So if the information is complementary, the prediction ability tends to get better. For example, in a recent published studies utilizing a convolutional neural network model found that adding two genomic biomarkers they add to histology image data and the predictive ability of patient prognosis got improved by 5%, meaning that the additional data integration can add some valuable information to understand the disease behavior. So the bottleneck in the data integration is obviously the sparsity of the data when we merging two different data sets, such as blood data and biopsy data. The number of patients who exist in both two different data sets gets smaller. And also in that case, we might observe the overfitting of the data, typically when we have a lot of more features with less patient. So the important next question will be that whether or not we can apply those published findings to our own patient. And to answer this question, it is very important to evaluate generalizability and reproducibility of the published finding by conducting, for example, independent validation study, as I think Kun mentioned.
Thank you, Reiko. I wonder if you could expand a little bit on what the biggest challenges are around different data sets. And inevitably, the data you're looking at, if it's environmental data and molecular data or histopathology data, exists in different places and often is structured in different ways. How do you solve those challenges, and what do you see as the greatest barriers to being able to integrate that?
Yeah, the greatest barrier, as I mentioned, is the sparsity of the data, consequently data missingness of the data, and overfitting. So for the missingness of the data, for example, in our cohorts, when we merge DNA sequencing data set and the RNA sequencing data set, we only have 200 patients with available dose information, although we already identified more than 3,000 colorectal cancer patients. So, which means that in our analytical sample, those analytical samples might not be the representative of overall colorectal cancer patient within our cohort. So some possible sampling bias exists. So we can re-weight those patients so that, for example, in our example, older patients are less likely to be included because of the quality of the specimen or some technical variability. In earlier years, we couldn't retrieve all the tissue from the patient. So those information, to recover those information, we can re-weight older patients to have good representative in the weighted analytical samples. Or we can do multiple imputation method. We can develop those imputation method. It highly depends on what kind of model you're using, but those techniques should be also implemented. Overfitting, as I said, typically when we have a lot of more features with less patient can be observed. So it is very important to have novel machine learning techniques that can be trained with, more efficiently trained with less data. That can improve a lot about our AI research in pathology.
Great, thank you.
So we hope we've given you an overview of the kinds of things that are going on in the field. At this point, we'd like to open it up to the audience for questions, and if there aren't any questions, we have additional things that we can talk about from our perspective. But at this point, if you have questions, please use the microphone. Usually when Dr. Aronson.
So, great panel. I have a curiosity question as to what you think that this will mean for pathology departments as a whole going forward.
Yeah.
Because it sounds like there are elements of this that will save pathologists time, the virtual, consults, but at the same time, also it sounds like there's tremendous opportunities for net new services associated with analyzing high-dimensional data for clinicians. And I'm wondering, do you see a need for more pathologists, less pathologists, and do you think if there's a risk that pathologist bandwidth becomes one of the limiting factors for being able to introduce these kinds of techniques?
So I can take an initial stab and let the panelists follow. Pathologists have seen a number of disruptive technologies come in over the decades. And if you look at how the discipline was practiced 40 years ago, John talked about shaking tubes and holding them up to the light. Now we can do millions of tubes without doing that. So there have been multiple times where the field has had to reinvent itself. And I think most of us see this as a major opportunity to do additional things. And there are examples already where the technology is just going to make things far more efficient. Probably the best example that's in practice right now is automated pap smear screening. In the past, pap smears were all read by technologists who screened back and forth across the slides. There was a moderate number of misses where the technologists would miss a diagnostic field. As a result, the technologists were limited that they could only read a certain number of slides in a period of time. And as a result, we were typically about 3 weeks behind on reading routine pap smears. Today, a lot of it's based on a liquid-based approach, going through an image analysis system, and it does a better job than the technologist at not missing something. So the sensitivity is higher. And then when the pathologist and technologist come in the morning, we see the ones that the machine was worried about. And we now have much, much quicker turnaround times. We're able to really throughput things in a much more effective way. So I think you'll see a balance of both much more efficient work going on, but also the enabling of really new ways of looking at things, some of which you've heard about today. Others want to field that?
So I'll just add, Sandy, I think that what pathologists do today is going to be different from what pathologists do tomorrow. That there's going to be tremendous added value. And I look at it very simply like immunohistochemistry. Immunohistochemistry was introduced in the 70s really, and really at a large scale in the 80s. When that was done, there were, and immunohistochemistry, for those that don't know, is just a way to identify proteins in cells. And when that was brought on, a lot of people thought, oh, we're not going to look at H&E slides anymore. We're going to look at these immunohistochemistry, and it's going to tell us exactly what that tumor is. But instead, what that's done is expanded to understand that biology is actually much more complex, and that we needed to actually study the H&E and integrate the immunohistochemistry. And now you can say the same thing about molecular diagnosis. You integrate that, and we're becoming better and better at providing diagnosis, providing treatment stratification, providing the ability for patients to go on clinical trials, prognostication. These are all, they've become better because of all these added new innovations that have occurred over the decades. And I see that artificial intelligence is going to do this in the laboratories, in the molecular lab, in the blood bank, and in anatomic pathology. And by integrating it, as you've heard, we're going to be able to think about the patient, I think, a little bit more holistically around all of that data to be able better to give the information back to their clinical providers to be able to better care for that patient, providing what people often talk about, the right care at the right time in the right place.
Other comments?
So I'll just make one comment. I think as David mentioned about efficiency, I think the first step is using these methods to ensure that everybody gets treatment that achieves whatever the current best standard of care is. And the way that's going to happen is these automated methods will help pathologists answer questions that pathologists and physicians are already trying to answer. We already know we need to answer that question. But I think the real frontier is moving that standard of care to a higher level, and that's going to involve using existing data to answer questions that we don't even know can be answered with this data yet, and that's where I think these methods will help.
Please.
I was wondering how you deal with black box issue in pathology detection, which is machine learning is famous for, but sometimes clinicians doesn't like it.
Yeah, maybe Joe, you could comment on that, because when Joe's been developing his machine learning models for genomic data, he's dealt directly with that issue.
It's a great question. So one of the elements that we faced where that we saw our own predictions. So basically there's a John and an iJohn tool. And you can see what your own model would predict, immediately raising the question, why? So exploring why a machine learning model does a certain decision like it does. Like, why did this variant came up with a 98%? It doesn't make sense. I would have not called it. Those were the questions. So what we did from that score is basically an exploration tool to visualize the decision that the machine model used. So as an underlying logic, we used a random forest tree, which had 15 branches of decisions, meaning after modeling, the model ultimately settled for a most reliable first initial set of decision, and then the cadence of subsequent decisions form an individual branch in that decision tree. So to allow us to actually explore why the machine learning model did a decision like it does, we basically traced that random forest tree back and visualize all of it. And we found really interesting things. Number one, you can explore why your own model does certain things. That shows things that I never even considered or that we didn't consider. So for example, the absence of another variant of finding in a case may trigger you to say this finding should be reported. And you can trace that back and see the individual weights. So I think it makes our data set that is already very rich and cannot be explored much more explorable. So in a way, we implemented this to explore the black box. So it is not just data in and result out. We really wanted to understand why the decision was made. And just to add something for the clinical setting, it is a human who ultimately clicks the button yes to report. But we could totally roll this out as a black box that just pushes out the data. But right now, we really want to understand why the decision was made like that. And I hope that answers your question. Is that?
And I mean, the key here is that you've changed the black box to a potential discovery tool itself, which is fascinating.
And we had one lung cancer case recently on a very new drug, which was just approved. And while the patient had a disease progress, there was a new biopsy taken. So this is a drug, no resistance mechanism has ever been described. The machine learning tool called a resistance, in this case in EGFR, that we have never, ever seen. So it shows that this system saw a pattern that we couldn't even know. So no one of us would have actually called it. So when we reviewed it at a consensus conference, we all agreed that must be the finding. And about 2 months later, some of the papers came out that reported this particular mutation as a resistance mechanism in this particular gene target, which was incredible because at this time we just said, well, this may be something, but the machine learning model just found it by seeing a pattern in those hundred thousands of data points. So
Kun, I think thought about this quite a bit with image data. So do you want to tell about your experience?
Sure. Definitely, this is a very important question on the interpretability of the machine learning models. Especially many of the machine learning models are pretty much like a black box. Input, output, and we let the machine figure out what is right. And our approach is trying to visualize what is correlated with our outcomes of interest. For example, we first train this deep learning model, and we try to visualize what has the higher weight in making this decision box, deciding is tumor type A versus tumor type B. And there are several ways of this visualization we are currently developing. For example, one way is to show back to the user what are the top-rated features associated with tumor types. And by examining those features, we can get a sense of whether the machine is reading the right thing or maybe it's focusing on the wrong thing. And another approach we are using now is about the attention visualization. So this is a way of asking the machine that where it put its attention on in this whole slide. And suppose it focus its attention onto the tumorous part when detecting tumor, then we know that it's probably working in the right way. So by these visualization tools, we're able to correlate these black box features with our input and output in a sensible fashion.
I think what you're hearing is that both with molecular data, with image data, by having the methodologies that we develop here, we're actually able to go back and interrogate and ask questions about the data that allow us to actually dive into what that black box is actually making decisions about. And that will ultimately help, again, help educate us. It will lead to new discovery, but it will also help in terms of understanding what's actually happening as these artificial intelligence methodologies are deployed. So next.
Take it a little different. You're talking about stretching the kind of data or information you can get from measurements. What kind of work you're doing to connect the question in the clinic to making the right test ultimately? And related to that is if you have limited resources, how do you know which patient should get the limited resources?
I mean, Joe, your group has started to think out this in the cancer realm with some of the collaborative work you've been doing with oncology to develop databases where you can do it. Do you think that's a way to get at the question?
Yeah, so we built, I think it's Long Lee, who's our chief architect. I think he's speaking tomorrow about this. So what we did is create a data lake to get all kinds of data. I mean, this is including, let's say, billing and reimbursement data. These are indications. These are hospital stay times. All of it, the full rich data sets to start exploring it. Basically, the meta-label analysis. Is that what you're getting at?
Well, a little bit of the physician in the community has a zillion tests that they could order. How
Correct.
do they know which one's going to give them the answer to what they have?
So maybe just a practical example, what we built using this whole data set is in GI malignancies, we worked with the Gastrointestinal Cancer Center group to settle on certain tests that we know from this data set that would actually change management. Mm-hmm. So instead of giving every single, let's say gastric cancer specialist the option of ordering 4 or 6 or 12 tests to try to do everything, and I think just sort of the gut feeling is we always want to do the best and most comprehensive workup, but we were able to convince them based on data, to settle for a certain panel. And we rolled that out basically by the organ site, the stage, and then the test type. And that led to something quite remarkable. It wasn't that it was the convincing that mattered. It was that they said that ultimately they have so much more time because they know with this stage and this cancer, we know that the patient will get the appropriate workup. So I don't know if that's a...
John?
So I think,
John, maybe your A1C and...
Sure, and in just more traditional lab testing, we currently have great tools for clinician order entry support. So if a patient has a thrombotic episode and the clinician wants to order tests to assess for various hypercoagulable states, the panels will enable the physician to make sure all of the common things are looked for. I think looking forward, what would be really powerful is if we could use all that data that's collected to figure out, are there some bases on which we could predict ahead of time maybe a couple of tests in those panels are most likely to be the explanation, and then we can save the money of testing for those other analytes. But that's going to require a lot of development work.
Okay. I think Vanderbilt has a team of pathologists that work with clinicians to figure out what tests to be done.
Good afternoon. I'm Jim Gannon with Pure Storage. I'm going to go down a slightly different path. I had a question for the panelists on the greatest challenges facing the technology leaders that are tasked with building the infrastructure that's needed to take advantage of machine learning algorithms and deep learning algorithms. And the context is really environments where we see data growing exponentially up and to the right, largely fueled by machine-generated data. The second consideration is the fact that most of this is unstructured. Right? About 80% of all data today is unstructured. It makes it challenging. And then finally is the challenge with consolidating data when it's coming from disparate sources, and you need to be able to capture and process in real time. So I'm curious, what the panel is seeing and observing relative to how infrastructure needs to shift to take advantage of some of the advances that are available with these algorithms.
Anyone want to tackle?
So I'll start out with that, and then maybe some of the other panelists will go. At Partners, we've certainly been plagued with exactly what you're talking about. And our solution to that so far, and I'm not saying this is an ideal one, is to create a separate structured data warehouse. So we've actually created data feeds, pulls that come out of our pathology labs, come out of the EMR, and they actually get structured into a separate data warehouse, which actually is structured in a way that you can vertically interrogate through that data in a way you couldn't do because it is unstructured. It's not that it's unstructured in these other areas, it's structured differently in these other areas. And that's the biggest problem we have with a lot of that data. And so our first solution, which I agree is not an ideal one, is that we've created this data warehouse that is a kind of sitting on its side and allows us to do these polls and interrogate the data.
Maybe Joe, do you want to comment based on the digital image? Because if you're using the histology images, which are huge files for research, it's very different than if you start thinking about it for clinical purposes. Do you want to comment on some of that?
Yeah, so I think you're aiming also at who creates the infrastructure. So I think the biggest problem is in a pathology department when we talk about slides, typically there's only one pathologist using one slide once at a time with one microscope. When we talk about one of the big advantages of digitization is there will be multi-tenancy mode. It will be distributed. Someone has to upload it into the cloud, and someone has to compute all of this, meaning the infrastructure for distributed computing has to be there basically from the get-go. And so far, no one has really thought this through. We looked into this recently. If we would scan all our slides from 1 year, just as a histopathology lab of our size of an academic medical center, there would be 0.2% of the entire World Wide Web in terms of storage. So we're talking petabytes of image data. I think we approached several companies. What would be your suggested solution? This is going beyond Amazon Web Services because you have to have not only the storage but a retrieval infrastructure from the get-go with multiple individual pathologists, and they don't want to wait half an hour, right? Because then they say, well, I can pull the slide from the file in 2 minutes. So it's enormously complex, and the part that is currently a big hurdle is there's no standardized file format, meaning every single API is built for what you describe as unstructured data. Mm-hmm. So I think in the molecular field, given that everything comes out of a computer pretty much, is already structured. I think we heard some examples to get features out of a slide is creating quantitative histology, but the metadata of all of that is enormously complex. Pipeline versioning, people who do the code review, and once you change one single item, how to check that. So I think it will create a drift for completely different trainees and computer scientists that have to work with pathologists to make this work.
Super, thank you.
Hi, good afternoon, everyone. My name is Matt Pettigrew. I work in the field of digital pathology, specifically to use computational methods to quantify fibrosis in liver and NASH. My question is to Dr. Yu and all of you. We talk about platforms, methodologies, capabilities. What are the criteria that you want to use to prioritize the focus of your teams on specific applications? You talked about cancer. How are you going to create your funnel?
Our focus is mostly on cancer because it's a widespread problem, and also many of the cancer patients have their histopathology slide as their basis of their final diagnosis. So currently we are mostly focusing on cancer because of the availability of the data and also the potential impact that we can inform, say, patient prognosis and the treatment options. But we are also expanding into other different diagnosis types, especially for rare diseases. For rare diseases, it may be very difficult for pathologists to come up with the right diagnosis at the first time because the prior for that rare disease is pretty low, and also the pathological changes may not be familiar to many of the general pathologists. So that is another area we are looking into right now.
And maybe just to add on to that, do you view the types of algorithms you're developing for cancer as having applicability for things like fibrosis or other, let's say, disorganization of the myocardium in the cardiac disease or things like that? Would you be able to use those same algorithms, or do you think they need to be all new algorithms developed?
That's a very important point. So right now, many of our deep learning methods, I believe they should be applicable to many types of indications. And the reason is because for the deep learning method, we no longer need to extract the features we believe to be useful. Although having some prior knowledge may help, but by bypassing that initial step, it can help us to learn directly from the data. So that is, given sufficient number of cases, we'll be able to, through a technique called backpropagation in deep learning, to identify the features that is correlated with our input and output of interest. So in our previous experience, as long as we have like several hundred to 1,000 of cases, we will be able to identify the image patterns associated with diagnosis with pretty robust results.
Right, but that doesn't stop you from a comprehensive validation phase in that specific indication.
When I think about prioritization from a pathology chairman point of view, I think about what are the low-hanging fruit that are going to lead to increased efficiency so that you can say this system is providing added value and we want to invest in it more. And that, I think, in general, for at least the anatomical pathology side, are screening applications where there's a huge amount of human time, highly paid human time, screening in certain organ systems where if you could improve the efficiency of that screening, you'd have a tremendous impact on the day-to-day practice in the pathology lab to say, wow, this was worth the investment. That's where I think the low-hanging fruit are.
Thank you so much.
My name is Richard Frank. I'm Chief Medical Officer of Siemens Healthineers. My question pivots from your point that there have been many disruptions to the practice of pathology and radiology over the years. And for the most part, these have been seized as opportunities for improvements in the practice of medicine and pathology and radiology for the benefit of the practitioners as well as for the patients. And I agree wholeheartedly that the example that you gave, AutoPAP, is an excellent advantage, an excellent example. But AutoPAP has been around for about 20 years, and it effectively augments the role of the pathologist, whereas many of the examples you've given now not only augment, but you might say emulate the role of the pathologist or the radiologist, and perhaps even go beyond that. So my question is, what do you think will be the success factors from a regulatory standpoint, a reimbursement standpoint, or even adoption when augmented intelligence or emulating goes beyond what we have now to this future? What will be the success factors in getting these products actually to benefit patients?
You know, I think it's it's trite to say, but it's what is the value-added proposition here? The kinds of things that John was talking about that we can't do now that we will be able to do in the future. Some of the things you heard about off of the molecular testing where you can actually identify something that we didn't have the capability to identify last year, or in the case of the digital imaging where we can detect things on slides that we couldn't detect before. So the idea, at least in my simplistic mind, is that we don't do the terribly boring things that we do now, and there are many of them, and we are doing far more exciting analytics to get the patient more information. But I still see all of that as the province of what a pathologist does. When a lot of people say, well, you're a pathologist, you look through the microscope. And my answer is no. What the pathologist does is derive clinically meaningful information from biological specimens. It doesn't matter what the technology is to pull that information and do the analytics. So again, I'm perhaps chronically optimistic about this, but I see it as providing added value, and yes, we won't be doing the same things as Jeff said, but I think we'll be doing equally, if not more important things down the road.
And I think that just going to what Reiko Nishihara said, when she did her studies on colon cancer, if you look just at the histopathology, you would have never figured out that there was a better prognosis with a patient doing a simple thing like taking aspirin. If you looked at just the epidemiology, they never came up with that. It was integrating the various things that pathologists do, getting to the point that David just said. It's not just looking through the microscope. It's being able to have the ability to think through the many different components of this that pathologists do for providing not just diagnosis, but prognostication, the treatment stratification, the clinical trials. And those efforts are what, when you look at reimbursement, those are the things when you can show that value, that is what is being reimbursed. And actually, David and I with our departments have gone to some of our insurers, and that's how we've gotten some of the work that we're doing reimbursed around, particularly in the next generation sequencing domain.
Perhaps the most apt quote that I've heard is relative to radiology, which is that AI won't replace radiologists, but those radiologists who use AI will replace those who don't. And I think that's similar for pathology.
Hi, Tom Westerling. I'm a senior scientist at FIMIC. We have a cloud-based platform called Iphoria for AI-derived machine learning or machine learning of surgical pathology slides. So my question is, we have around 40-ish research-validated algorithm ranging for cancer, liver fibrosis, lipid accumulation in the liver, malaria detection from blood smears, et cetera, et cetera. So everybody have their, their analysis that they want to do and their algorithm that they want to implement. But how do we as a field get a throughput so that we can actually get some of this technology used in the clinic? Because every single algorithm is a body of work. Getting into a clinic is even a bigger body of work. And how do we actually get to that point for not only 40, but hundreds of these algorithms? And then a follow-up, a side question of that, how do we cover things like incidental findings? If you run one algorithm on a slide and then the pathologist just reviews and says, okay, I agree. If he would have used 15 extra minutes and gone through the slide, he would have found another disease that was not suspected, but it still is there and it will become clinically significant. How do we not miss those? Thank you.
Maybe to your first question, I think currently there's no standard for, in your case, histopathology data. There is a DICOM standard released by the Working Group 26, and we currently have big efforts at the entire partners level to roll out a true implementation, a cloud-based implementation for the DICOM standard.
Yep, we're working with DICOM or within DICOM, but even DICOM has different levels of variability.
Different layers and different complexities. So what I think a good analogy is, the old Atari game stations with the little cartridges. Currently, there's tons of companies who have 500 cool games in cartridges that don't match any of our game stations.
Yep.
So I think it's actually a data format problem right now. And the next one will be the infrastructure. And then I think it unleashes the power of all those algorithms. So I think in relation to the former question from the gentleman from Siemens is, I think it will change what we do every day in becoming more a technology or an algorithm assessment type of pathologist. Like similar to what in CP, what's happening in CP, we're not counting cells, but we're assessing technologies and roll those out clinically if they're meaningful. And as part of our job, we have a Center for Integrated Diagnostics, and we do just that. So in case you have any product that you think is ready for prime time, I'm happy to talk to you.
So I think the applicability to clinical setting is the important thing is to have common or standardized image, for example, image processing, management, or data augmentation technologies, including how to identify, remove artifacts such as bubbles or understaining, overstaining, how to do color normalization or those kind of things. So we have to also share those information to have the common data processing and management pipeline so that we can apply those computational method in the same background sample, analytical samples. And as I said, it is really important to have independent validation studies that include patients with different characteristics from different populations that will add that is different from cross-validation, which typically include the same pool of the patient from one hospital setting or another hospital setting. So that's also an important aspect, I think.
And I think, sorry. Yes, go ahead. I just want to quickly add that in addition to the infrastructure issue that we haven't really solved yet for anatomical pathology, there's another layer of workflow issue. Once the data is digitalized and standardized, we still need to have an integrative machine learning system that look at every single disease of interest rather than run model 1 for disease 1, model 2 for disease 2. And also we need to further integrate this AI workflow with the current clinical workflow. That is, where we put expert pathologists in this system. Do we put it after the AI has made the initial screening, and how do we come up with a way to consolidate the different predictions from different AI models?
And I think this comes back to what we were talking about a minute ago, that this is not likely to replace pathologists anytime soon. It's going to augment what we do. And to David's point about the low-hanging fruit and doing the screening, those are the first level, but then those cases are still going to go across the eyes of a pathologist who's going to help identify those incidental findings and other things. And I think that's going to be critical to continue to do.
Yep. Thank you.
Hi, my name is Jeff Yim. I'm with Northwell Health Labs. My question is for Mr. Yu. Have you found that with regard to digital pathology, specifically the slides, is there a requirement or need to make that easier through standardization? I know that in our labs it's still very manual in terms of just the slicing of these biopsies and putting them onto slides is still a manual process. There's still a human involved, and how that affects sort of the digitalization, and then also the then applying AI to that sort of quote digital image. And if it's not standardized, then it make the digitalization harder as well as the application of AI harder? So is there a need in the front end for that sort of standardization where every slide is 1 micron or whatever it is?
Important point on the standardization, on the digital slide preparation and segmentation. So for the standardization, we believe that the more standardized the slides are, the better the machine learning model would perform. Because many times, if we have a limited data set and we run through this machine learning method, they may try to find any correlation associated with our outcomes of interest. So some of the spurious findings we got before is like some of the batch effect are readily picked up by our machine learning models, because like from certain hospitals, they are more likely to be referred a certain type of disease. Then our machine learning model is not immune from this batch effect. So for those without standardization, we need some statistical model to account for that. And with standardization, I believe we can further unleash the performance of our machine learning to the next level. And then the related question is about the manual segmentation, and that was an indispensable part for many type of the conventional machine learning models, where we still need some technicians or pathologists to like circumscribe the regions of interest and feed those regions into our machine learning models. And things have changed pretty quickly in the recent years. In one of our previous models, we use some prior knowledge, encode that prior knowledge into some specific rules, and use those rules to identify the regions with most likely our disease of interest. For example, some changes in inflammation, necrosis, or tumorous regions. So those could be further automated by either a rule-based system or a machine learning-based system. One of the approaches we are currently applying is on the attention neural network, where we can train a model to identify the regions with potential interest. And with this approach, we can automate the segmentation process as well.
Your question, though, highlights one of the real big challenges for digital analysis, which is that when you think about radiology, the information coming in is already digital. We, as you well know, have a whole process before you get to slide scanning that has many, many variables associated with it. Recently saw an interesting AI presentation on image analysis where there was variability, and when the presenter was asked, what is your major source of variability? It was the staining of the tissue and how uniform the staining of the tissue was. It had nothing to do with the step after you got to the digital format. It was all related to stuff that happens beforehand. So I completely agree. This is a huge source of variability that we in pathology are not easily going to get around.
Next.
Maybe time for one or hopefully two quick questions, because we have about 5 minutes left.
All right, thank you. My name is Tich Mangono. I work for the Clinton Health Access Initiative, and we work in 25 developing countries, and a big part of the disease burden in the developing countries is infectious diseases, but more recently we're seeing the rise of non-communicable diseases. And I think it looks like we're having great progress in terms of sort of the data and the software pieces, and sort of even the knowledge and the skill to diagnose the different diseases. What I wanted to ask about is one of the major problems is the hardware is still very expensive when you look at it in terms of the different countries that we are working in. So I wanted to, and I do think that there's an ethical and also business and business case there in terms of like bringing accessibility to sort of like some of these tools. So I wanted to just ask if in the work that you're doing, have you seen sort of progress around simplifying the tools, making them more affordable or even accessible and flexible for sort of maybe remote settings where you might also have sort of a market there and even sort of a business case in different countries?
You know, I mean, telepathology, looking at images from a distance is one of the more straightforward aspects of digital pathology. And the question is, how do you make it cheaper and easier to get those images to wherever they can be effectively read? I'm certainly not an expert in it, but we've seen neat examples of very cheap adapters for phones where they clamp on to the end of a ocular for a microscope, and you can take images with just a phone that's of very high quality for transmission. But it's not an area of expertise for me. I don't know, John?
So I'll just mention, I mentioned earlier the impressive technology in clinical lab instruments, and actually Siemens has an ADVIA 120 hematology analyzer that's been on the market, I think, for 30 years and is available virtually worldwide, and that instrument collects data that we're currently looking at, so we can look at someone with a slightly high white blood cell count and try to predict, is this someone who's got an infection that will come to light next week, or is this somebody who's more likely to have a leukemia that won't be diagnosed for 6 months? Since that data is already collected with this 30-year-old instrument, all we need to do is transfer it somewhere with even a cell phone, and the analysis could be done.
So, last question.
My name is John Davis. I'm the CEO of Proteocyte AI. We predict your risk of developing cancer over the next 5 years. The biggest challenge that we face is what you've talked about right from the beginning, is access to data. And how do we create a more friendly atmosphere for hospital networks across the country and industry to share that information? Because that's the biggest part that's slowing down the growth.
One of the big problems there is again, getting to standardization. You know, we've gone to Epic, but our Epic instance is different than, you know, the next hospital over that's put an Epic installation in. And so I think one of the challenges that is going to continue to plague this field in really democratizing this is coming up with standards. Just like you've heard today, as we move to try and figure out, and we're here at Partners working hard to try and work on a DICOM standard for pathology, similar to what radiology has done, because radiology has done this. You can get a disc from almost any place, you can put it in your computer and you can read it and you can look at it and you can review it. You can't do that today with digital pathology. You can't do that with most other things. And we need to figure out ways to do that. And without that, it's going to, there's always other issues around HIPAA and around other things that are going to continue to challenge it. But until we have those kinds of standardizations, it's going to be nearly impossible.
So the other part of your question, though, is besides the technological obstacles, it's the business model and political obstacles. So I'm on the Partners Data and Tissue Sharing Committee, where we have discussions every time we meet, which is at least monthly, about how do we interact with industry to provide data sets in ways that protect our value, but yet share these data sets with society to bring improvements to medicine. And what we've seen is a wide variety of how different healthcare institutions deal with this, from ones that are much more protective of their data to others that are much more on the side of sharing the data. Where the right point is in that, I don't think anyone knows yet. I can tell you from our perspective here at Partners, we are, fortunately or unfortunately, on the more protective side. But I'm not sure any of the leaders of the committee would say necessarily that that's the right place to be. It's the place that we've chosen to start at, and we'll see how things go. A lot of what we see is the development of case law. As we see each one of these proposed interactions with industry, we weigh the pros and the cons, the details of the contract, and make individual decisions, literally, on it, with the hope that that's going to build up to more comprehensive policy approaches to it. But it's a really tough issue right now.
Reiko, did you want to say something?
Yeah, so from the methodology side of view, it is also very hot area to train the machine to learn efficiently with less data. Incorporating, for example, prior knowledge from other study or prior parameters some other people already found, or even, for example, theory. We usually, for example, medical student read textbook, or those kind of non-data theory can be also fed into the computational algorithm to learn more efficiently with less data. That will be, I think, future very interesting real AI technology.
Great, thank you. So we've actually come to the end of our time. And since there's no one standing up to ask any questions, we think this is the right time to end. We thank everyone for being here. We hope you've gained an appreciation for where AI will be moving in the area of pathology. And when we talk about pathology, we're really talking about a broad swath of what healthcare is altogether. So thank you all for participating. Thank you for the questions. And we appreciate it. Yes.